So this is an example of the way which I would approach a patient with headache. So what I would do is initially I would go to across the top here in the differential diagnostic dashboard, and I would find headache. And I've actually got it already open on the screen here and click through to that. So now this would be the sieve view for the patient with headache. Now what I would do is I would be seeing the patient, and they would be 38 years old, so I change the age bracket there. It was a male that I was seeing, because I'm going to think of a real case which I saw, and this person had had a headache for about 36 hours. So now what I would do is just very, very quickly remind myself the common causes of headache for 38-year-old men that come over a few days. So I would sort of scroll down and see that I've got migraine and tension headaches, I've got concussion and post-concussion, medications can cause it, ENT infections can cause it, dietary and stimulation and drugs can cause it, depression, epilepsy, and then dehydration and diabetes. And I'll also just very quickly remind myself of all the worrying causes of headaches. I've got subarachnoids and thromboses, CVAs, fractures, extradural, subdural hematomas. I've got severe infections, and I've got neoplasms as well. So now what I would do is I would familiarise myself with some key aspects. I would now go and also just check along here. So what sort of things I want to ask in history? I want to ask if there's any redness or swelling in the head or face, whether they've had especially any trauma. And I remind myself of the red flags here. Have they got a history of cancer, immunocompromised? Was it sudden onset? Do they have meningism? Is there any neurology that they're noticing? How severe is the pain? And looking to see if they've got a red eye. Over 50, I know, is a worrying symptom as well. And then there's some things that I can look at is already on the OBS chart from the nurse. Do they have a fever? Are they hypertensive? Are they tachycardic? And then think about some of the things I'm going to examine. I'm going to examine the ears, the eyes, look at the skin. I'm going to examine the throat. They might have already had some investigations done as well. So I could already tick off the fact that actually I know they're not going to be pregnant. They might have already had a normal urine. They've probably already had a routine set of bloods which involve calcium and CRP and glucose. So a lot of information I can already glean. I can change those as I was, but this man hadn't had any tests done yet. So what I then would do is go and take a thorough history examination, and then come back and review his investigations. Now at this stage, what I knew was that he actually didn't have a history of cancer. He wasn't immunocompromised. It wasn't sudden onset. He had no meningism. He told me he had no neurology either, and I would examine him as well, but it was severe pain. So at this stage, as you can see, there are some little subscripts which will come up here to show me that subarachnoid, hemorrhagic dominant hemisphere CVA, cerebral venous thrombosis, cervical spine fractures, and hematomas, eye issues, and some of the infections actually have very, very severe pain. Just going down as well, there was a number of other things he said, and he didn't have any neck stiffness, hadn't had any recent procedures, no, so that removes post-procedure, and no medication change there, so it can't be that. At this stage, I also know that he's afebrile, he's not hypertensive, he's not tachycardic, and he had a normal throat, normal ears, nothing to see on the skin, and a normal eye exam. Also, once bloods came back, I saw that he had normal glucose, normal calcium. CRP was not greater than 100. He obviously wasn't pregnant, and he had a normal urine, which I asked for as well, red cell count and white cell count. So at this stage, there's still a number of things that are left here, and there's one red flag which has popped up. So now I would go to the rank view, because the rank view changes this from just general approach, and then actually puts it up as a top to toe. And in a study which I did, it showed that 95% of the time, the diagnosis included in this dose summary for Middlemore for 1,000 patients was actually found in the top 20. There's a number of other questions here. So this patient actually did have a couple of vomits as well. As you know, redness and swelling there. It had no trauma. It wasn't frontal. And he had no history of fevers. He also did have a history of migraines, was the other one of the important things here as well. I didn't do a chest x-ray. So at this stage, when I'm thinking about my 38-year-old man with a history of migraine, he's got vomiting and severe pain. Number one is migraine again, and I can actually click over that, and I can remind myself of the key sort of symptoms here: headache, vomiting, a bit of an aura, which he didn't have in this situation. Sometimes they get neurology, and some of the treatment here, which often are tried, and the fact it's a clinical diagnosis. I actually would just go here and just have a very, very quick look at Migraine Pro, and just reading down a little bit about the types of classifications as well, just to remind myself about migraine here and some of the treatments. What I would do is, because I'm actually relatively confident with this diagnosis, I would just check once again how many high morbidity things there are here. Now, even without a history of trauma, subdural hematomas can come from quite minor sort of injuries that tend to happen in older patients. So I'm just going to change that back to the age bracket correct. And just be aware that there are sort of the occasional sort of metastatic subarachnoids which do pop up just here with having that one red flag. But because those are really aren't in the top sort of 5 or 10, and I'm pretty confident it's not a subdural hematoma, then I'm pretty happy just to go with the diagnosis of migraine and treat for that. And this patient actually went home based on these facts. Now, if any of those red flags, if there's 2 of them, they would be moving up a lot higher, and I would be considering a CT scan and lumbar puncture as the 2 investigations if I was really wanting to rule out subarachnoid. And the other thing is if I do a chest x-ray, which is normal, then that would be the way to rule out lobar pneumonia. So with headaches, we often treat first. We often know that a lot of them are dehydration, concussion, tension headaches. Migraine often get the same treatment, and the key question is whether it's CT, subdural, metastatic disease, subarachnoid, residual pressure, and then those 2 obviously are, and lumbar puncture is often needed as well. That's the way that I would go through it, using the dashboard in multiple views and multiple ways to help with learning.